Heel pain is a very common disorder. It's estimated that 1 in 10 people will suffer from it at some point in their life. The main diseases that can cause it are Achilles tendinitis, calcaneal bursitis, fracture of the heel bone, and plantar fasciitis. Of this, by far, the most common cause of heel pain is plantar fasciitis, which sometimes leads to the appearance of a heel SPUR. The highest incidence of plantar fasciitis in the general population is between 40 and 60 years of age, both in men and women, and in up to 50% of patients, the problem occurs simultaneously in both feet. The plantar fascia is a band of fibrous tissue that runs along the bottom of the foot, just below the skin. It originates in the calcaneal bone, that is, in the bone that makes up the heel and extends to the front of the foot, where it divides into 5 segments that are inserted into the base of the proximal phalanx of each toe and into the heads of the metatarsals. The plantar fascia is made up of 3 bands, medial, central, and lateral. The central one is the thickest and strongest, and it's also the one that is most frequently affected in plantar fasciitis. Plantar fasciitis is the inflammation of the plantar fascia as a result of prolonged exposure to overloads, tensions, or contusions, which causes over time tears and microtraumas at different points of the fascia fibers. The chronic inflammatory process in the insertion area of the plantar fascia produces a metabolic change at this level that favors the deposition of calcium salts or uric acid, and over time it can give rise to a bone extension called calcaneal SPUR, which consists of a bony protuberance in the form of a beak, which can measure up to 1.5 centimeters in the inferior-anterior part of the heel. The main causes of plantar fasciitis and eventually calcaneal SPURs are standing or walking for a long time, perform activities that cause strong impact on the foot, such as running or similar sports, metabolic disturbances, for example, gout or diabetes, rheumatic diseases, overweight, wearing inappropriate footwear, and presence of alterations in the structure of the foot, such as flat feet, cavus feet, and so on. The characteristic symptom of fasciitis, with or without a SPUR, is chronic pain in the sole of the foot, and especially in the lower part of the heel. The pain is usually more intense when taking the first steps in the morning or after a period of physical inactivity. Although the SPUR is sharp, heel pain doesn't usually occur due to the puncture of some structure around it, but rather due to the local inflammatory process generated by repetitive microtraumas. Therefore, it's common for patients with heel SPURs who complain of heel pain to also present with plantar fasciitis. Changes in weight-bearing patterns resulting from foot pain can lead to secondary injury associated with the knee and hip joints. Over time, patients may experience progressive plantar pain, which may cause lameness and restriction of activities such as walking or running. In addition to pain, patients may experience foot stiffness. Inflammation, on the other hand, is rare, and when it does occur, it's minimal. The diagnosis is established by medical history and physical examination. In the interrogation, it's common to discover risk factors such as those mentioned above, that is, spending a lot of time on your feet, playing sports that involve running, metabolic disorders, etc. On physical examination, the patient experiences tenderness in the anteromedial area of the calcaneal bone and along the plantar fascia. The pain is increased by forceful dorsiflexion of the foot and toes, as well as by extension of the knee. In diagnostic doubt, and as complementary resources to rule out other diseases, X-rays and ultrasound are mainly available. In the case of the existence of SPURs, the plain radiograph shows bone growth at the level of the plantar tuberosity of the calcaneus. The growth appears as an extension of the bone in the form of a lens or beak. X-ray also help rule out other disorders such as fractures or tumors. However, there is no radiological clinical correlation with plantar fasciitis, since up to 50% of people with heel SPURs don't experience pain. Therefore, radiographs do not confirm the diagnosis regarding the origin of the pain. For its part, ultrasound allows the thickness of the plantar fascia to be measured, and a thickness greater than 4 mm is considered a positive diagnosis of fasciitis. As for the treatment, in principle, the inflammation of the plantar fascia should be reduced. When the inflammation of plantar fasciitis subsides, pain attributed to the heel SPUR when present usually subsides as well. Treatment can be divided into non-invasive and invasive. The first comprises 1. Resolution of risk factors, that is, metabolic control, body weight control, restriction or suspension of physical activities that represent a prolonged overload or that aggravate pain, and use of shoes with special insoles so that they don't exert pressure on the calcaneus bone and the plantar fascia. Is recommended, for example, the use of sports shoes with a soft and wide heel. 2. Physiotherapy exercises. This should focus on stretching your calf muscles, Achilles tendon, and plantar fascia. 2 examples are illustrated here. The first consists of sliding the heel and the plantar arc of the foot on a plastic bottle with frozen water, making it rotate on the floor from the base of the fingers to the heel and vice versa. Another complementary modality consists of changing the bottle for a tennis ball. These exercises can be performed for 5 to 10 minutes per session. The second exercise consists of standing about 60 centimeters in front of a wall with one leg in front and other behind, as if you were walking. Place your hands on the wall and lean your body forward, keeping the soles of your feet glued to the floor. This position should be maintained for about 30 seconds. Rest a little and repeat the exercise about 3 more times. There should be no pain, only the stretching of the calf muscles should be felt. Physiotherapy exercises can be performed in the morning and at night and should be continued for days or weeks until the symptoms disappear. 3. Pharmacological treatment. The use of non-steroidal anti-inflammatory drugs is recommended for 1 to 2 weeks. For example, ibuprofen or diclofenac can be indicated. These medications may be prescribed in conjunction with physical therapy exercises. If no improvement is observed after all the measures described above have been exhausted, the patient should be sent to a specialized service, where invasive treatments, including steroid injections in the heel and surgery, could be resorted to. However, both injections and surgery should be considered only when all previous remedies have failed and symptoms last for more than a year. Currently, these 2 methods are very rarely indicated, since the vast majority of patients achieve pain relief from plantar fasciitis with non-invasive treatment. In addition, neither infiltrations nor surgery guarantee cure in 100% of cases, and they're not free of side effects.